All right, interesting things in the hospital, part 4. This is super cool, but there's this database that our infectious disease pharmacist uses that gives her like an expanded view of sensitivities with cultures. So in the hospital, patients will get things cultured, like their urine, their blood, little lumps that are oozing stuff. Sputum if you can hack up a good sample. Anyway, so a culture is basically like what bug is growing. Culture takes a couple days to come back. If it's like acid fast bacteria, like tuberculosis, it's going to take a few weeks. Slow growing. A sensitivity will literally tell you what antibiotics will cover the organism. S means susceptible, meaning that antibiotic will work against this organism, Pseudomonas. Intermediate is kind of like in the middle. And R is resistant. You can't use the antibiotic for the organism. Of course, it's a lot more complex because we're pharmacists. So sometimes you have inducible resistance. So say it says susceptible, and certain antibiotics will trigger resistance mechanisms in bugs. So you got to be aware of that. Also, of course, as a pharmacist, you have to make sure that the antibiotic is getting where it needs to go. For example, the UTI, you got to make sure that antibiotic is renally cleared. It needs to get in that urine. Other little fun stuff, like if you're treating pneumonia and you use like daptomycin, won't work. Lung surfactant deactivates that antibiotic. Anyway, the ID pharmacist has a database that shows, again, an expanded view. So the little chart I showed you only showed like maybe like a few antibiotics, like 4, 5, 6. She has access to a database that will show a ton of antibiotics and the susceptibilities. This is so that providers don't order stuff that they really shouldn't be. So antibiotic resistance is a huge issue. It is a global issue. We should not be using broad spectrum antibiotics when we don't need to be using them, especially if you have a susceptibility chart. And for your nerds out there, I'm going to give you an example of inducible resistance. Some bacteria produce something that we call AMP-C resistant enzymes. These can degrade first, second, and third generation cephalosporins, penicillins, and can even overcome like Zosyn. An example of a bug would be Serratia. You really want to avoid Piptazo or like ceftriaxone. You can consider narrower beta-lactams if it has susceptibility to cefoxitin and you have infection source control. Serratia is actually an example one that might possibly harbor the gene that produces AMP-C beta-lactamases. A bug that likely has it is Enterobacter. So in treating that organism, you don't want to use ceftriaxone or piperacillin tazobactam or narrower beta-lactams because, again, inducible resistance, even if the susceptibilities show susceptible, a day or two later, boom, could be resistant.